Assalamu alaikum, everyone. It's a real privilege for me to be able to speak to you today on the added value of calcium scoring to perfusion imaging. I'd like to thank Dr. Noman and the rest of Pakistan Society of Nuclear Medicine's organizing committee for this tremendous opportunity. So we've known for a long time that SPECT has been a workhorse for the assessment of chest pain. And there's very good reasons for it. Number one, it has very good diagnostic capabilities, as well as this slide on the top right corner shows, that it has good prognostic value as well. As the degree of ischemia increases, patients have increasing cardiovascular events. Similarly, those findings of diagnostic and prognostic value have also been shown with coronary artery calcium scoring. We know calcium, when we see it in the coronary arteries, identifies the presence and extent of atherosclerosis, and it correlates very nicely with total plaque burden. And we know from the slide that we see in the top right-hand corner that as your calcium score increases, your risk of having a cardiovascular event progressively increases. Whereas those patients who have a calcium score of 0 have an excellent long-term outcome. Now, more and more scanners in today's market are what we call hybrid scanners. They have both a CT machine that's attached either to a SPECT or a PET scanner. And the CT allows either attenuation correction, radiotracer localization, or the performance of a calcium score. But it also allows us the opportunity to evaluate both myocardial perfusion and an anatomical assessment of atherosclerosis with calcium scoring as part of the same exam. And for the rest of my talk, I'd like to show you how the combination of nuclear medicine for a functional assessment for ischemia and a non-contrast CT scan for coronary atherosclerosis combined can improve diagnostic accuracy, can improve risk stratification, and also possibly improve outcomes. So I'm going to begin with a case. This is a 52-year-old with a BMI of 40, hypertension, who was seen for a pre-op prior to surgery. And you can see this fixed perfusion defect on stress and rest images across the anterior wall. And if you look on the bottom right, you can see there's normal wall thickening and ejection fraction. I think most of us would feel comfortable, given this patient's body size and what we're seeing in the raw cine data, that more than likely that this is simply attenuation. But the question that I have for you is, does your confidence increase if I showed you the patient's calcium score? And here the patient had no demonstrable evidence of coronary calcium. So I think you'd all agree you'd feel much more comfortable that this was due to soft tissue attenuation rather than due to coronary artery disease. And of course, this patient also had undergone prone imaging, and you can see on the prone images, which are the middle set of data, the perfusion images are completely normal. What about this case? This was a patient who had just stressed imaging, and the nuclear tech calls you and asks you whether you want rest images. Here you can see a mild perfusion defect in the inferior wall, a common place where we associate with diaphragmatic attenuation. But what if I showed you a calcium score that showed tremendous amounts of calcium in the right coronary artery? I think we'd all agree this would be a patient that we would not want to take any chances, proceed with a rest image, and to see if possibly this perfusion defect we were seeing was due to ischemia or not. And this is really what the literature has shown, that when you have knowledge of the calcium score, it increases your interpretive certainty. In this first study on the left, 151 patients had interpretation of an MPI with and without the calcium score. And what they showed is when you added the calcium score, you significantly decreased the equivocal studies and increased the normal or ischemic studies. So you were much more confident in your interpretation. Similarly, in another group of patients who had stress imaging, and then data was interpreted in a stepwise fashion with calcium being with calcium score being added last in order to determine the need for arrest and PI. They also again found that, without the calcium scoring, you were more likely to obtain a arrest study, whereas once you added the addition of the calcium score, it decreased the need for arrest study by almost 64%, again here within that borderline or equivocal group. So here's another case to kind of drive home the point. Here's a patient with kind of a fixed defect on the inferior wall between stress and rest images, and the prone images in the middle are completely normal. Ejection fraction you can see is normal. So by perfusion imaging, this was a normal study. However, if you look at the EKG, stress EKG, this patient exercise, you can see that the patient had 2 millimeter ST depressions and actually had symptoms at peak exercise. In addition, when the patient underwent a coronary artery calcium score, you can see the arteries were chock full of calcium, and here the score was actually quantitated to 1800. So, we felt very uncomfortable calling this study normal with the EKG changes, the incidence of chest pain with exercise, plus the evidence of severe atherosclerosis within the coronary arteries. We pushed for further imaging with a coronary angiogram, and sure enough, the patient had triple vessel disease, and the nuclear perfusion images were a false negative, most likely due to balanced ischemia. So then, what does the subcoronary atherosclerosis actually mean? So here are two patients, patient number 1 and patient number 2. As you can see, both of them have perfectly normal perfusion studies. However, patient number 1 has no demonstrable evidence of coronary atherosclerosis, and patient number 2 has pretty significant coronary atherosclerosis in the left system. So the question I have for you are these the same patients, and will they have the same prognosis? Now, before we answer that question, I just want you to know that finding atherosclerosis is very common. This was a 20-study meta-analysis in patients who had completely normal perfusion scans. And the incidence of finding a calcium score greater than 0 was 72%. And what equally shocking was if you looked at these normal studies and looked at the incidence of calcium score greater than 400 or a severe coronary artery calcium score, 25% of these patients had it. So it's not unusual to have a completely normal SPECT study but have evidence of atherosclerosis. So what does this all mean for the patient? Well, we try to answer this in our own institution. We took 1,100 generally asymptomatic patients who had both a calcium score and SPECT and were followed for approximately 7 years for major adverse cardiovascular events. And what you can see is, what has previously been shown in the data, that as your perfusion defect size increases on SPECT, so does your incidence of cardiovascular events. Similarly, as your calcium score increases, also you have a proportional increase in cardiovascular events. So, this was nothing new and had already been seen. But what we tried to do was explore the interaction or the interplay between calcium scoring and perfusion imaging. So we looked at, in this patient population, what is the prevalence of an abnormal SPECT exam in relation to their calcium score. And you can see here that as your calcium score increases, your risk of a perfusion abnormality proportionately increases, to the point where those with a calcium score greater than 400 had a 30% chance of having an abnormal nuclear study. Similarly, if you had a calcium score in this study less than 10, it was very unlikely that you were going to find a patient with an abnormal study. And in this particular study, I can tell you all these patients were a false positive result. This has also been previously shown in the literature. And this is just 4 studies that, again, here with pooled analysis shows you a calcium score of 400. Here in this pooled analysis, almost 26% had an abnormal myocardial perfusion image, whereas those with a calcium score is less than 100, it's very unusual. So did this study add new to the literature? So first is looking at the relationship of cardiac events based on perfusion findings and coronary artery calcium scoring. And you can see from this top left graph that as your calcium score increases, again, your risk annual event rate proportionately increases. But what was interesting to see is that at the moderate or severe degrees of coronary calcification, those patients who had an abnormal SPECT had a much higher event rate than those patients who had a normal SPECT. So that was one important finding. Another important finding was that if you just looked at those patients who had a perfectly normal a nuclear result, and I'm showing you the Kaplan-Meier curves here in the bottom left portion of the screen, you can see very nicely that for about 2 to 3 years, most patients do well. And this is really the warranty period of a normal nuclear myocardial perfusion study, where it can range from about 2 to 3 years. But then after that, you can see that the curves start diverging, all in relation to what the patient's calcium score is. So what this tells us is that your short-term risk, is dictated by your nuclear myocardial perfusion study, whereas your long-term risk is dictated by the total amount of atherosclerosis that are present in your coronary arteries, as indicated by your coronary artery calcium score. And this study went on to show that when it comes to, diagnosing cardiac events, by adding calcium score to nuclear imaging, had the highest accuracy when by global chi-squared statistics. So what about a cardiovascular PET? As you know, from this study also done by Dr. Mullah at our institution, it can show you very nicely, as we've talked about before in the top left screen, that as your calcium score increases, your risk increases. Also, similar to what was shown previously in the literature, that those patients who had an myocardial flow reserve less than 2 did worse than those who had a normal MFR greater than 2. But what this study uniquely showed was that if you were to look at the relationship of calcium scoring, MFR, and annualized cardiac events, you can very nicely see that cardiovascular events increase as calcium scores increase, and that no matter what the calcium score is, if your MFR is also less than 2, you have a much greater degree of MACE compared to patients with the same calcium but an MFR that was within the normal range. Again, so they're suggesting that there definitely can be further risk stratification performed by the addition of myocardial flow reserve. Now, these aren't the only studies. There's a lot of studies in the literature and that have looked at the ability of hybrid imaging for diagnosis and prognosis. So here's another case I wanted to, now that we have this information, this was a 63-year-old. You can see here there's kind of a fixed perfusion defect in the inferior wall between the stress and rest images, which completely normalizes with prone imaging. Now, if you just had only this data, I would ask you, how would you treat this patient? Now, while you ponder that, also consider if I went on then and showed you his calcium score, and in this particular case, the calcium score is at least moderate with a score of 313. Now you know the patient may be at a small short-term risk, but definitely at increased long-term risk. Now how would you treat your patient differently? And I really hope, yeah, you would between the two answers, I really hope with the addition of the calcium score, you would do something different. And why is that? And the reason is very simple. Prevention is better than cure. With coronary artery calcium scoring, we have the chance to identify subclinical disease, and we have the opportunity then to institute risk factor modification and pharmacotherapy before disease gets more advanced and these patients develop adverse cardiovascular events. So most of the guidelines, here's a summary slide of that, and you can see right in the middle there that will recommend for those patients with a calcium score greater than 100 that you consider statin therapy. Whereas if your calcium score is normal at 0, this is a patient who's at very low risk, and you can consider withholding treatment and repeating anatomical imaging between 3 to 5 years to see if they've converted and need statin at that time. But if your calcium score is more than 100, most guidelines, all guidelines recommend the addition of a statin. Now, when you look at studies to see the performance within physicians, this was a study of 6 studies. You can see that with the knowledge of a calcium score, physicians were initiating aspirin, initiating lipid-lowering therapies, initiating blood pressure control, and patients were exercising more and changing their diets. So knowledge of a calcium score does have an impact on the physician as well as the patient. This was further seen in the Eisner study, which was a randomized trial of patients who had risk factor counseling with and without a calcium score, and they nicely showed that in those patients who had the calcium score at 4 years, they had lower cholesterols, better weight, and lower blood pressure than those patients who went simply counseling based on risk factors. So knowledge of a calcium score really changes the behavior of the physician and the patient. And we will see in the future that calcium scoring may be used to help us identify the highest risk patient population who would benefit from newer therapies which may be more costly. So in the end, the question is, well, are we going to save lives? And though we don't have outcomes data yet, there are about 5 clinical trials that are actively going to be answering this question. They're listed here on the screen, so stay tuned. We will have an answer shortly. But if some of these registry data suggest, hopefully we'll see a mortality benefit. In the Walter Reed data, which was a retrospective study, those patients who had a positive calcium score and were treated with statins had a survival benefit compared to those who weren't. And in 4 randomized clinical trials of chest pain, those who had anatomical imaging and were initiated on medical therapy early demonstrated a 31% reduction in non-fatal MIs. So, we hope to see benefit in those trials. So in summary, I hope I've shown you that, the old way of doing things is ischemia and no ischemia. We should get away from this. We really should move to, where we perform atherosclerotic imaging with our functional studies and report that the patient has no ischemia, no atherosclerosis, no ischemia, positive atherosclerosis, or ischemia plus or minus atherosclerosis. So thank you for allowing me to speak to you today. The hybrid imaging guidelines mentioned on the right can be a further resource if you'd like to read more about this. I'm approaching the end of my time, and I'll leave the summary slide open so you can review what we have gone over. I'd like to again thank Dr. Noman and wish everybody Assalamu alaikum. And I apologize that I was not able to be with you.